Dr. David Gross, psychiatrist.
And I'm Dr. Andrew Rosen, psychologist. And welcome to Two Shrinks and a Mic. Today, we're going to talk about something called trauma. Everybody's heard of trauma. It's been a pretty popular topic in our field, and certainly you hear about it in the media today. And we just wanted to spend some time talking about trauma, explaining it, and talking a little bit about what to do about it.
In a lot of respects, psychological trauma is undiagnosed or diagnosed not as frequently as it should be because it's people don't ask the questions. It's tough to ask somebody if they were ever physically or sexually or emotionally abused, or to get more specific about how they were treated as a kid. But it's there beneath the surface. And a lot of the people that I've seen, about 30 or 40 years ago, I began to be aware of the prevalence of psychological trauma when I was consulting to a women's addiction program that catered to individuals who had lost everything. They had no money, no insurance, lost their families, lost their jobs because of addiction. And they had asked me to come by and see several of them to see if there was anything other than substance abuse as a problem. And when I got histories, I was just amazed at the percentage of these women who had traumatic experiences either as an adult or as a child that continue to plague them to this day, and almost to a point where a lot of their substance abuse was a way to treat the emotional pain that came from the trauma. So that years and years ago got me focused on trauma, and the more I pay attention to it, the more I see it in the individuals that I meet with.
You know, up until fairly recently, trauma was only discussed in terms of, at least diagnostically, when somebody was involved in a disaster, such as a plane crash or war or some really severe situation where people were either killed in front of you or you were involved in some almost death experience. And up until maybe I guess it's a decade or two now, that was the only time we would talk about trauma, other than, if we really want to go back far, there was a guy named Otto Rank who talked about birth trauma, which was, his idea was that each one of us has suffered from trauma when we were born. Now, that theory has been pretty much disproved or discarded, but we've all had certain forms or aspects of trauma. There's probably nobody who hasn't. And there we define it based on if a person experienced something as really scary or traumatic or painful or really tough to deal with or get over. So we've broadened out with the definition of trauma a lot.
Yeah, I think the whole concept of birth trauma, it was not fair to the mothers who had to go through the horrible pain of childbirth. The field of trauma, though, I think has been unfortunately underserved by both of our professional societies. And that's because our diagnostic manual talks about post-traumatic stress disorder, which is like a classical trauma syndrome. But then it doesn't really talk about the whole spectrum of trauma. It has what's called adjustment disorders, which are stress-related disorders, but really doesn't highlight the nature of trauma. But I think it's important to recognize that post-traumatic stress disorder is just the extreme example of trauma itself, but there's a lot of other less intense trauma-related disorders where individuals will tell you that they've never been happy, they have chronic depression, they've abused marijuana to take care of some kind of emotional pain that they can't put their finger on. And in addition to that, when you talk to individuals and try to determine whether or not there's a trauma history, for a lot of people, it's memories that they want to forget about. In fact, in many respects have, and sweep it under the rug or are just too embarrassed to talk about it. And I've had numerous occasions where individuals I've interviewed will tell me that I'm the first person they really told about the abuse or the trauma that they experienced when they were younger. For a lot of people, it's then a relief and gives them a chance to say, gee, boy, I'm glad I got that off my chest. And then it allows you to begin to talk about what you need to do as a next step.
One of the models that I kind of like to apply to the concept of trauma, just philosophically, but also talking with patients, is the earthquake model. And we know when there's if you've been in or you hear about or see a major earthquake where buildings have fallen and people are buried under the rubble and there's deaths and that sort of earthquake, that is the severe trauma, the one that you just talked about, the most severe type. But there's other degrees of earthquakes. I was in one years ago, and it was terrifying. To me, it was traumatic, although there was little damage to buildings and so on. But the experience, which only lasted maybe a minute or two, was really traumatic and lasted with me for quite some time. And even today, I remember it vividly. So if you apply that kind of continuum model to the kinds of earthquakes that one can have, I think in life, there are different degrees of earthquakes, so to speak. And there's the type that were maybe like involved with 9/11, but there's also the type where maybe you witnessed a crime or somebody broke into your home or you was devastated by the sudden loss of a loved one and so on. Those are also traumatic, but they don't meet the criteria that you would from a 9/11.
Modern trauma understanding comes out of World War I. There was even some talk about trauma-like syndromes out of the Civil War. That's really what developed our concept of trauma. And as a consequence of that, post-traumatic stress disorder became a very specifically diagnosed disorder with a criteria that had to be met. I think it's important to recognize that not everybody exposed to wartime trauma will develop PTSD. And those have been interesting studies because you can look at 100 soldiers who got exposed to combat at a similar level of trauma and fear and fright. Not everybody develops PTSD. In fact, it's really a smaller proportion that does. And there's some theories now that there may be a biological or genetic predisposition to the development of PTSD. In the beginning of our nosology, of our diagnostic system, to have PTSD, you had to experience a near-death experience, plane crash, car crash, or war where you almost died and thought you were going to die. That definition has been broadened significantly. So now if you're in an ICU visiting a loved one and see them suffer and all that they go through in severe illness, that is now included in some of the triggers of what a trauma syndrome can develop. And so it's much more than just being directly exposed to the trauma. And individuals who, during 9/11, as you said before, individuals who were in the area, even a mile away, who got exposed to the fear and the fright and the running of crowds and the injuries, developed PTSD, even though they were not in the buildings. And so it's a diagnosis now that has been brought into other traumatic experiences.
One of the things that I think is involved with trauma and why it can linger goes back to what we've talked about in different circumstances, and that is the survival instinct. Our brains are wired to watch out for a threat, watch out for danger, watch out for anything that could be dangerous to us. And so if you've been through an event, or even if you know of somebody who's been through an event, your brain is wired to make sure it remembers exactly what that event looked like, smelled like, tasted like, and what color it was, when it occurred. And your brain is trying to make sure that you never are unprepared for it again. And that is why you see the ripple effects. One of the reasons why you see the ripple effects of trauma go on and on and on. Talk about 9/11. The difference is I had a patient who was able to flee the building that came down and never, ever went back to New York, and actually moved away from New York, and actually for 3 years was a shut-in because of it. And yet, one of the people she worked with, who also got out of the building on time, basically went back to work within a few weeks. And so, not in the same building, of course, but we are all wired differently. But the common denominator is, for all of us, make sure whatever almost got us doesn't get a chance to get us again. And that's why we've learned a lot about why the brain kind of has this tattoo of the experience and will linger in terms of its effect on emotion, mood, behavior, and leads us into, well, okay, a little bit we can talk about that, about what are the treatments that can help erase some of that damage.
The last time we talked about attention deficit hyperactivity disorder, and in the process of discussing that, we talked about how much our brains can either focus on what's going on around us, or if you have a disorder like ADHD, attention may not be that good. And therefore, if you don't focus on information outside of you, it's not going to get stored in the brain. We store stuff in memory areas of the brain for both long-term memory and short-term memory. We now know that in trauma syndromes, people store too much stuff. And it's the emotional relevance and the emotional valiance or power of a traumatic experience that gets it stored tenaciously in a part of the brain called the amygdala, which is a very primitive part of the brain that exists in crocodiles. In fact, it's an important part of the brain for regulating emotions and survival, so that traumatic experiences get stored there very strongly, and oftentimes they can be there without conscious awareness. However, if a situation develops that reminds you somewhat of the traumatic experience, like a Vietnam vet who's walking down the street and a car backfires, which sounds very much like an explosion, that Vietnam vet may then have a startle response, may suddenly have a vision of what he or she went through in Vietnam. And what that means is that powerful set of emotions and experiences that got stored in the amygdala suddenly is released to consciousness. And to this day, Vietnam vets will continue to have, unless they have adequate treatment, PTSD-like symptoms that can be either spontaneous or triggered by external events. And so you can't view PTSD as purely a psychological, I wasn't strong enough to prevent it type of syndrome. It's really a brain phenomena. And because of that, many of the new treatments have been directed at trying to help individuals be able to get rid of some of those painful emotions and the images that get stored in the brain.
I can recall in 1980, I was driving from a meeting back to my clinic, and somebody came from the other direction and made a turn into the traffic that I was driving in. I lost control of my car, went into a gas station, and just about hit a pump that would have blown up for sure. And I can remember it vividly, sitting and talking about it. A few months ago, I was driving towards Gainesville, and a similar situation occurred. And not only did I get really anxious and upset from that event that just happened, but my brain immediately remembered that situation from 1980. It was as if it happened a minute ago. It is a brain thing. I don't have any doubts about how our brains are wired to never let go or never really fully assume that this thing that happened won't happen again. So the treatments are geared much more towards that. One of the things that we know, though, is that if you've been in trauma, the best thing you can do is be debriefed about it, meaning you're going to talk about it. There's something about being able to review this situation as quickly as possible, using language that has a good effect on reducing the impact of it over a long period of time. Not sure what that's all about, but the debriefing is very important. And certainly in the military, they've learned to do that. And even in rescue situations with paramedics and things like that, debriefing is important. But the brain is always what's in charge of everything. We've learned that. It's not purely a psychological event. It's a neurological event as well, as you say.
The Israelis have had, unfortunately, a lot of experience with trauma because of decades of bombings and et cetera. And so there's a lot of literature on trauma experience and trauma treatment there. And they've talked about, in doing studies, initially having an approach where He'll debrief somebody immediately after the traumatic experience. In fact, in the U.S., the ambulance drivers, police would often do that at the scene. They realized that that was a mistake initially. Debriefing has to occur, but the first thing you need to do for a trauma victim is make sure they feel safe, comfortable, and no longer in a fear-generating situation. After that, once they've calmed down, at some point down the road, they can be debriefed. And one of the other things that I discovered in reviewing a lot of that literature was the fact that individuals can often be exposed to repetitive traumatic experiences. The initial concept of post-traumatic stress disorder was you're exposed to one horrendous trauma: plane crash, car crash, war, rape, mugging, and that's it. But now we recognize that there's trauma that can be cumulative. A lot of research now suggesting that persistent childhood trauma, like parents who are emotionally or physically abusive over years, can probably be more devastating over time than somebody who has an experience of one major traumatic episode. So we have developed this concept of complex trauma compared to the notion of just PTSD. Unfortunately, the complex trauma is yet to be in our diagnostic manual, and hopefully eventually it will be. But complex trauma means that your brain has been repeatedly emotionally assaulted, so to speak, and often requires more extensive care and treatment.
Perfect example of that is the child who lived in a home where when daddy came home, there might be an explosion of some sort, maybe because of drinking, maybe because of just bad temper, bad relationships. And around 5 or 6 o'clock, there would be an episode, and the child would learn, much like we learn a lot of things around the clock. That's the time of the day where it gets scary. And I can't begin to tell you how many times I've worked with adults who report, and they don't know why, at a certain time of the day, usually it's around dinner time or at the end of the day, they start to feel anxious. They feel like something is going to happen, something's coming. And it's amazing how connected that is to the sorts of situations in childhood that can occur. Even in an adult who I can recall had a husband who used to intermittently be violent, and years later, no longer married to him and married really in a good marriage. But if she was in a quiet room and all of a sudden, and typically would be if the husband came into the room unexpectedly, she would almost panic until she realized, no, this is the present and that's my current husband and it's good. But it would be almost like a reflex based on past experience of trauma. It's complex trauma. It's not major, the types we sometimes think of with trauma, but these are traumatic scenarios.
We both treated individuals who we've described as having lifelong problems with maladaptive coping strategies and traits where they have problematic relationships, they make bad decisions, they're impulsive, have difficulties with trusting. Many of them end up having the diagnosis of borderline personality disorder. But what is really striking is when you do an in-depth evaluation of these individuals who have what we used to call and still call personality disorders, you find out that there's a history of trauma. And one of the ways that I try to help people understand the ramifications of trauma is to picture a wagon wheel, the old-fashioned wagon wheel when people went out west in the 1800s, where there's a hub in the center of it, and then there are spokes coming out of the hub. And so each of those spokes can represent one of the manifestations of trauma. So, for example, it's not uncommon to see eating disorders, especially in women, as a manifestation of trauma. Substance abuse, problematic relationships, persistent depression are examples of the spokes that come out of that wagon wheel. And one of the core components of all of that is, if you're lucky, you come out of childhood with the concept of basic trust, that the world is a safe place, raised by reasonable parents, and you believe that you can trust people and establish relationships and move forward in your life. But if you don't have that kind of childhood, basic trust is not there. And if anything, if there's enough trauma, you come out of childhood with a suspiciousness and a lack of trust, feeling like it's not a safe place. And that's a painful experience to have as you're trying to grow up, and certainly has a negative impact upon self-concept and ability to rely on yourself in the world. And so trauma is much more than just having flashbacks or terrible dreams or signs of depression. There are a lot of what we call comorbid difficulties that develop out of people who have experiences with trauma.
It definitely leads to a whole approach to the world. And it's not something you're necessarily conscious of. But if the first stage that we used to talk about of needs of childhood is trust. We used to call it trust versus mistrust. So ideally, or hopefully, a child would overall develop a feeling of trust in the environment, trust in the people in the environment. But if you don't have that, if you have mistrust in the people in your environment, mistrust of the world, it really then gets pushed forward. It becomes ingrained. And so now in childhood, in young adulthood, in adulthood, you approach the people in your world and the world itself with mistrust. And think about how that affects your ability to engage in relationships. Think about how that influences your ability to enjoy life or build an optimistic mindset, which we all know is a very important thing if we can have optimism. And if you've been through these little minor repetitive kinds of traumatic environments where mistrust is formed, it's really very, very hard to ever get rid of that. And so, it's just something to be aware of when you're a parent and you think something that happened was no big deal. It may have been a really big deal to that child. One time I was talking with a young man who said he remembers when he was a little boy, he heard his father say, "That's the straw that breaks the camel's back. I'm not going to be here so much anymore." And it was devastating to that child. To the parent, it was just like, "Oh, I had an angry moment and I didn't mean it." But that can influence a child's sense of anticipation about what's going to happen and a whole buildup of mistrust in everything. So, those are traumas. Those really are traumas, and they do accumulate, and they do require much more intensive treatment than somebody who's been through a very specific short-term trauma.
Part of the process of treatment starts with education. Both of us have had individuals coming in who describe problematic relationships. Why do I always pick this bad guy or bad woman as a spouse, and turn out after a year or two of marriage that it's been a nightmare? And why have I had all this depression? And have no idea why they're drinking like they have, or have developed the eating disorder, or et cetera, can't keep a job. And once it becomes clear that trauma is a component of their lives, then understanding that may be a trigger for a lot of these other maladaptive behaviors is helpful as a first step. And just educating people and saying, it's not your fault, like in Good Will Hunting. That's a very powerful message to give somebody, that, you're not a screw up. You're not doing this on purpose. You're not doing it volitionally. It's almost as if your coping skills and your defense mechanisms have been negatively influenced by the trauma that you had to survive. And then help people recognize that we do need to help you move forward. It's sad that a lot of the people I've seen who are clear trauma survivors end up getting just routine psychotherapy. And I'll ask people, have you ever seen a therapist who focuses on trauma or provides a specific form of treatment for that? And oftentimes the answer is no. And that's often the missing ingredient for a lot of these individuals. And next time, I'm sure we'll have a chance to talk some about treatment, which still is being developed. I mean, it's still a field that we don't have all the answers to, that we're still learning about, but we know a lot more now than we did 30, 40 years ago. But don't want people to think that we're giving you a bad negative message and all is lost. It isn't. people can recover from trauma and move on and have healthy, productive lives.
You know, one of the things in our culture today that we try to get people to identify and reduce is this feeling of being a victim. Because when you identify as a victim, very often you can develop a mindset of helplessness, and there's nothing I can do about it. And if I hadn't been victimized, everything would be fine. So we try to discourage that victim mentality. On the other hand, if you have been through trauma, some of the types that we've described, that you were a victim. You know, it wasn't like you were not a victim, but being a victim does not have to lead to a mentality that identifies oneself as a victim forever. So you can be a victim for the moment, or for the hour, or even for many periods of your childhood or even adulthood, but you don't want to identify as a victim. There's a big difference. And that's what we can talk about next time, amongst other issues in terms of treatment that really can help people who have had trauma.
You know, if you think about it, a lot of what we've talked about in these podcasts, we've talked about anxiety, depression, ADHD. The concept of hope that we've talked about is generated by helping the individual we work with recognize that, yeah, they may have been a victim of depression or a victim of panic disorder, but we want them to become a survivor. And the survivor is a positive, moving forward, hopeful attitude rather than a victim who is stuck in the muck and can't get out of it.
Exactly.
And I'm Dr. David Gross, psychiatrist.
Dr. Andrew Rosen, psychologist, and hope this was informative for you. This has been Two Shrinks and a Mic, and we'll see you next time.
Bye-bye.
The Two Shrinks and a Mic podcast is for informational and entertainment purposes only. The views expressed are those of the hosts and guests and do not constitute medical, legal, or professional advice.
Please always consult a qualified healthcare provider before making any medical or wellness decisions. Our content is not a substitute for professional medical guidance, even though our mothers tell us we have the best advice possible.